Title of this evening's presentation is Effective Communication and Breaking Bad News. So I've given this talk to lots of people throughout the UK and Ireland, and people do find it quite informative. Obviously, it's a new CPD requirement by the GOC. So I'm just going to break down a bit what we're going to talk about. So we're going to talk about three different stages. Why is communication important to me? Obviously, we're communicating to patients, but also communication to people externally and in other kind of stores, other professions too as well. Could be a GP, could be an orthoptist, could be an ophthalmologist. You may or may not know there's three different models of breaking bad news. I'm not sure if you have any pre-reg students, but one of the OSCE questions pre-reg students may get asked is, which breaking bad news model do you use and why? And medico-legally, it's very important to be aware of the reasons why we need to have good communication. It's one of the main problems that we're facing now with people becoming a bit more litigious. So what is bad news? So I've got a quote here from one of the authors I'm going to mention quite a few times. His name is Robert Buckman, and he was an oncologist who found the Spikes method. And the Spikes method is one of the methods we'll be speaking about tonight, talking about breaking bad news. And he had a quote saying, "Bad news by any diagnosis that negatively alters the patient's view of his or her future." And the bad news is always on the eye of the customer. So we're kind of, come across it quite a lot. But for somebody going to the optician, maybe every kind of 2 years, 3 years, maybe they have an issue with their glasses, they can't see very well. They just think, well, my vision was blurry last time. I went and got a new pair of glasses. It'll be the same this time. And then we have to tell them, no, there's something wrong. There could be signs of ocular pathology, which is causing the blurry vision. Again, it's going to be a bit of a shell shock to them. When I was researching this article, I came across a couple of quotes, and these are the two kind of ones that I like the best. One by the Academy of Orthopedic Surgeons: "Patient will never care how much you know until they know how much you care." And my probably favorite one is down at the bottom. "And then people forget what you said, people forget what you did, but people never forget how you made them feel." And from my personal perspective, I can remember numerous times when people say to me, "Oh, you dealt with my mum very well last time," or "My dad had cataracts and you spoke to him very well. You showed great compassion and empathy." And on the other side of the coin, people come in to me and say, "I was upset the way you spoke to my daughter. She didn't want glasses and you said she needed glasses," or "You didn't let my son have contact lenses." And it's difficult to remember every conversation you have, but they will remember the conversation that you have with them, whether it be good or bad. And why is communication important in eye care? So we're probably here, quite a lot. People don't like going for eye examinations. They prefer going to get the teeth done, the dentist. They don't like the subjective nature. "I hate this part. I don't like the eye test." We need to obtain relevant information from the patient, and that's very simple, contemporaneous records. They may not have been for 2, 3, 4 years. Their general health may have changed. Their family ocular history may have changed. So we need to be able to extract information then as much as possible. And then vice versa, we need to deliver our information to them and reassure them that everything's okay. Your vision is fine. Everything's no problem. The glasses are okay. Or we may need to come back for another test, or may need to refer you. And we do that in a very kind of simple, clear manner to them. And as I said at the beginning, we're going to make information available to other practitioners, and that can be both internal, and that could be to maybe an optom to a DO, or a DO or CLO to member of staff. It could be external to another member of your practice, if you're maybe in a practice at 2 or 3 different stores, or it could be externally to a GP, an orthoptist, ophthalmologist. So just knowing that our communication skills are very important, both internally and externally. And why are we talking about communication all of a sudden? Because there has been a change in the GOC CPD requirements. And the number one reason for DOs and CLOs being brought to the GOC and the OCCS is lack of communication. So the OCCS is the Optical Consumer Complaint Service. So if the GOC get a complaint against a registrant and they don't think it's valid to do a fitness to practice procedure, they'll bring it to the OCCS, and the OCCS then will deal with the procedure and deal with the complaint and contact the registrant and the customer and get the full story. But basically it's communication, lack of communication. So when I was going to college and when Stuart was in college, there was nobody teaching communication, but now it's begun to come, more of a kind of, par for the course that there is communication courses. So the GOC requirements for universities, there's no mandatory GOC requirements, but now you'll tend to find a lot of the university courses offering undergraduate optometry are utilising that and bringing guest speakers in to talk about experiences to people maybe who don't have any experience. But if you do look at the kind of GOC standards of practice, which will all be judged against if something does go wrong, communication is very important. And what the GOC tend to say is the ability to communicate effectively with both the patient and any other appropriate person involved in the care of the patient. Now, that may be a partner, it could be a husband, a wife, it could be a child, it could be a grandparent, or it could be a carer, or it just could be a daughter or a son. And we need to be able to establish the communication links with the person themselves, the patient, and also with their carer. And for anybody who's just recently qualified, again, this wasn't a prerequisite before January 2022. So communication wasn't a requirement, but now it is a compulsory requirement. And we probably, in self-confession, kind of, are probably the last healthcare practitioners to, have communication. If you look at all the healthcare practitioners on the same par as us, maybe pharmacists, nurses, midwives, etc., physiotherapists, health practitioners, communication was a big part of their CPD. So we were probably the last ones to the table, the last ones to the party looking for communication. So other kind of guidelines with the standards of practice that the GOC have would be to listen to patients and respect their views, very important, and give patients information in a way that they can understand and make them aware of the options available. So we do have to be very aware of what we're saying to the patient. We can't just say you need to get this spectacle lens or this contact lens. We need to be able to give them an informed choice. And same if we're going to refer people or give them choice, or if they refuse a referral, we have to appreciate and respect their views. And that means they're fully involved in the decisions about their care. So this is the breaking bad news models. So you might want to just take an image of this on your photo or just write this down. This might be one of the questions you get later on. But talking about the three breaking bad news models, we tend to have spikes, A, B, C, D, E, and breaks. Spikes is the more popular one, and spikes was done by two oncologists, Robert Buckman and Walter Bailey. Robert Buckman, unfortunately, is deceased, but if you do get a chance to type his name into YouTube, you will see him. He's quite a well-recognized, familiar keynote speaker at conferences, and he was an oncologist who had to go around and speak to people in hospitals who had a terminal illness of cancer and explain that they're going to die. And he did it in a kind of a humorous way. So if you do get a chance, look at his name online. And the HCPs, the Royal College of GPs, again, if you go into YouTube, but they have a competition every year for physician students to do a role model video of how to break bad news. And also the American Academy of Optometry adopted as their kind of benchmark. So when they teach their physicians and optometrists and eye doctors, they'll use this technique, the spikes, and then we'll talk about A, B, C, D, and breaks too as well. So spikes stands for setting, perception, invitation for knowledge, invitation for information, knowledge, empathy, and summary. So we'll go through each one, but setting is, do you have enough time? So if you mentally prepare, you're going to give somebody some bad news. How are they going to react? Some people may be quite annoyed. They might be quite, angry with it. There could be an emotional outburst. You have to be able to prepare, what am I going to say to them? Where am I going to say it? How are they going to react? Perception, ask them about how much do you know about this eye condition. I is very important, inviting them information. Do you have any information you'd like to give me? And then knowledge, asking them about the knowledge. What do you know about this condition? Would you like me to give you some further information? E is probably the hardest one, empathy. So we're all kind of told that he wasn't empathetic, didn't understand, etc. And this is probably one of the hardest ones to teach. You can't learn it in a book, it comes from experience. And then we talk about S, which is summary and strategy, and do you check for understanding? And this is probably becoming more popular, and I'll talk about this later on in the presentation, but how do you know that the patient understands you? How do you know that the patient understands what you're saying? And how can you make sure that he will kind of, document that, and you can document that patient understood, rather than kind of say, maybe a year or two later down the line, they might kind of say, oh, you never told me so, or he never told me so. So making sure that you are aware that the patient understands exactly. So breaking bad news is not easy. Is the shop floor the right place for it? Probably not. If you don't have any other space and other consulting rooms are busy, then you might just be able to have a chat on the shop floor, but maybe bring them into a consulting room and have a one-to-one conversation with them. Obviously, you may see them in the practice. They may bring in a partner, a spouse, a child, a loved one with them. So when you go out to bring them into the consulting room, you may see somebody there with them, and that'll give you a clue then maybe if you were having difficulty or they were having difficulty absorbing the information, that you would have somebody to call on. And that tends to be a good one too as well. Involve significant others, especially if you are breaking bad news. It can be quite distressing and quite, upsetting for them. I used to kind of say, do you have anybody with you today? Was that your partner? Was that your husband? Was your wife? Or I always kind of say, yeah, my memory is not so good. Two memories are always better than one. Should I bring in your partner? And the majority of the time they'd say yes. The minority of the time they say, no, I'd like you not to bring them in. I'd like to do this by myself. Or I prefer them not to know. And that's what you have to respect their wishes. When you're talking to a customer, obviously, if you're standing, if they're standing, try to stand. If they're sitting, try to sit too as well. So you're at the same level, so to maintain eye contact. And if you can imagine, maybe back in school when you were a small child, looking up at your teacher and maybe getting kind of, told off of what you're doing, and that can sometimes be the way a patient might perceive us, that we're telling them what to do, maybe in a condescending manner or in an authoritarian manner, rather than kind of, a helpful practitioner. So sitting down and facing them, and body language, the non-verbal cues is very, very important. So look attentive and be calm. Eye contact is very important. We're in a profession where we want to be speaking to our customers, but you'd be surprised there still are practitioners out there who maybe aren't happy with eye contact, or some of our patients aren't happy with eye contact. And I'll come across this later in the presentation too as well. And then one very important one, which you may or may not have heard of, called active listening. And active listening is where you look directly at your patient and say, I'm here for you 100%. Please tell me how you're feeling. Please tell me how I can help you, rather than passive listening. And passive listening is where you're kind of maybe filling the patient record card. Somebody knocks on your door for another 16 collection, or you've got a telephone call. You're kind of saying, yeah, I'll be with you in one moment. Sorry about that. And go back onto this. And that's what we refer to as passive listening. While active listening is you're giving 100% to the patient. So here's an example of bringing a loved one into the consulting room for the breaking the bad news. Obviously, we have the healthcare practitioner. We don't really know who is getting the bad news, but we can see, a support network there. So maybe the person on the right-hand side or left-hand side is helping the other one, but it can be very important, especially with the breaking of bad news. So if you do have that opportunity, maybe if you do feel them getting a bit upset, you can offer that. Would you like to come back at a separate time with maybe a loved one or a partner? And that's a very good one to offer our patients too as well. So P in the spikes is perception. So what do you think yourself? You came into me knowing that your vision was blurry. You knew something was up. Did you think there was something wrong with your eyes? Maybe you've gone into a locum practice and the resident has asked a patient to come back. This is the first time you're seeing them. You're not really too sure what was told before. You might be able to say, well, what have you been told before? Have you been any concerned? Do you know the reason why I brought you back today? Sometimes with older patients, you may have to bring them back for maybe elevated IOPs, for cataract, for maybe visual fields not being as good. So sometimes you have to kind of tell them, I'd like you to come back, we need to repeat these tests. And you tell them we're going to do IOPs, we're going to do visual fields, we're going to do cataract. And then they come back a week later and say, can you remember what we're here for? And they kind of say, yeah, I'm just here for the cataract. Well, no, we're here to look at the kind of the visual field and the intraocular pressure. So just again, reconfirming why they're here, just to let them understand what you're doing. And again, asking them, are you worried about this? Are you concerned about your vision? And letting them know where you stand. So invitation, again, depending on the age range, if it's a younger person or if it's an older person, asking them, what level of information do you want? So engineers want all the information, teachers want all the information, while, your lovely old granny will just kind of say, just give it to me a small piece of sun, or, give me something that you'll kind of, can understand. How much information would you like me to give you about your diagnosis and the treatment? Would you like some patient information leaflets? And one of the kind of things when I began to do this presentation was looking at signposting. And I always thought signposting was you signposting people to maybe a website. And I had two websites down here, which were the College Optometrist website and also National Eye Health Week, which is on a couple of weeks ago. But since then, I've learned signposting is another term that you can tell somebody, I'd like you to give you bad news. So you'd say, Mrs. Smith, can I have a word with you for a moment? Or Mr. Jones, I'd like you to tell you something. And that can be seen as signposting too. You're getting them ready to impart some information onto them. And patient information leaflets are very important. Because you'll tend to find there's been numerous kind of studies about kind of, the level of information that's retained by a patient, not just in optometry, but in all kind of clinical information and clinical context, that the greater the amount of information you give them, the lower the proportion is recalled. So if you're asking them to come back in and check the vision and do Amsler, maybe thinking about a contact lens regime too as well, kind of, asking them to kind of, clean, rub and rinse, maybe cut a dry eye treatment in terms of heat, clean, etc., massage. The more information you give them, the more information they're likely to forget. And a lot of clinical papers tend to have different statistics, but the one that kind of is mentioned quite a lot is approximately 50% of what they manage to remember is incorrect too as well. So again, just making sure when you give them the information, when they come back, understanding that the information is correct. Something which doctors tend to use, which is called a shared decision making, or we maybe refer to as informed choice or informed consent, is integrate the patient into the care. So get them involved, but it can be difficult when, approximately 50% of the information that you give them is not retained or it's incorrect. When we talk about patient engagement strategies, so this is why we have to engage the patient. So we're trying to get a 50-50 communication. It can be difficult in a time constraint we have with eye appointments, especially in a high volume clinic. You might not have that time, but we talk about something called verbal dominance, that it should be a 50-50 conversation. If you're speaking all the time and passing on information, then you'll tend to find the patient has a slightly less chance of retaining that information. And that's a very buzzword again, which may be in the questions too again, is something called patient teach back. So you're explaining the situation in non-clinical terms, and you're talking about the treatment options, and the patient there kind of looking at you, nodding, and you're kind of thinking, is this information going in or not? And what you can do then is ask them to repeat the information you've given to them in their terms, and then you can understand have they understood you or not. And it tends to be very, very simple to use and low cost, low technology. And I've got some simple ideas here of what you could do. So it can be difficult to kind of say this without being condescending. So there's a kind of couple of examples of, just to be safe, I want to make sure you're on the same page. Can you tell me the reason why I'm referring to you? Or I want to make sure I explain things clearly. Can you explain to me what we said about your driving or about the hospital appointment? So trying to find one that you're quite happy with. And again, trying to do it in a kind of a nice manner without seeming condescending. Patient information leaflets are a great source of medical legal protection for you too as well. So when I was in practice, I was working in a practice that had a lot of ocular pathology, a lot of cataracts, a lot of glaucoma, a lot of macular degeneration. And I began to utilize patient information leaflets on a daily basis. And I'd always put down PIL, patient information leaflet, or COO, college optometrist, COPIL on cataracts given. And then maybe I'd see a customer, and before I take the customer into the room, I'd go in and have a brief look at my notes in the previous visit. I might say COO, college optometrist, PIL, and cataracts given. And I'd bring the patient in. I'd say, so Ms. Smith, last time we were here, we were chatting about the cataracts. No, you weren't. Sorry, yeah, I think we were chatting about the cataracts. No, you didn't. Oh, well, I've actually got here on the 6th of May, 2021. We talked about cataracts. I gave you patient information. Oh, okay, fine, you must have then. So, it's there for your defense too as well. And when you're giving somebody a patient information leaflet, get them to read it. From my experience, you give patient information leaflet to a lady, they'll tend to fold it in half and stick it in the bag. They won't look at it. And if you give it to a gent, they'll kind of fold it in half and stick it in their inside pocket of the jacket, and they won't read it. So when you're finishing off your patient record, give them the patient information. They've said, no, please have a look at it, open it. And rather than kind of, sticking the whole, fold it in half, they'll say, oh, okay. Yeah, have a look at it for 2 minutes while I'll just finish off the record. And they'll say, oh, right, okay, I'm with you. Oh, yeah, I can understand now. So depending on who you're with, maybe with a multiple or an independent, they may have their own range of patient information leaflets. Your professional indemnity insurance, whether it be AOP or photo, and college optometrist or abdo would have their own range of patient information leaflets too as well. And it's a great source of further information, especially if you don't have time. You can say, I'd like you to take this information leaflet and we're going to get you to come back in 1 week's time or 2 weeks' time. And I'd like you to ask me as many questions as you like, just in case you are stuck for time. So K in the Spikes method is knowledge. And again, this is probably one of the things we have to kind of try to get into our spiel as such. So when we're doing our pre-testing, we're doing our vocal ophthalmoscopy, we would probably say the same thing over and over again. And it's trying to kind of get one of these sentences that sounds sympathetic and also sounds empathetic too as well. Pause them to take a deep breath too as well, and use a short non-clinical terms. We're talking about medical jargon, so you've got to assume minimal health knowledge. And I was just looking at some figures before I came on today's presentation, and I was looking at a report that said 7 million adults read or write at a level of a 9-year-old. Okay, and 43% of adults do not understand the written information. So if you look at the Sun newspaper would tend to pitch their stories for the majority of people kind of a 9-year age, and that's why they're so popular. While the Telegraph and Guardian would be more kind of 14 and 15 upwards. So assume the people you're speaking to maybe don't have great health literacy, and maybe have to, how are you going to explain that? And it can be difficult, especially when newly qualified, but how can you explain a clinical term in a non-clinical way? When I was in practice, I always tried to give a tactile touch. It can just be a personality trait. Some people like it, some people don't. Depending on your age, you may feel comfortable with it, you may feel uncomfortable. I always found maybe a touch on a knee or a touch on an elbow. If they were crying, reaching out to maybe passing tissues. Again, you have to be able to try to be comfortable in your own comfortable zone. I was doing some safeguarding training recently with children and vulnerable adults, and they were talking about, what you should do, what's accepted, what's not accepted, and shaking hands, a gentle touch, while a hug would not be accepted. So you've got to be able to kind of bear that in mind too as well. So for some people, maybe with Down syndrome or learning difficulties, they may come up to you and want to give a hug. They're very loving people, but just be careful of what happens in the consulting room and outside the consulting room too as well. Some people are very tactile, other people may not be. So when we talk about empathy, it's probably one of the hardest things to do, and probably females are much better than guys. And it's something that you can't really learn in a kind of a textbook, and it tends to get down to experience. And again, trying to kind of find a sentence that you can say to somebody with genuine heart without being, patronizing, and try to kind of find one that you're happy with too as well. I used to work in a practice, and even my consulting room, the guy was on the shop floor, and every time he'd have an apology, he always said, "I'm really, really sorry for that." And I must have heard it maybe 3 or 4 times every day, but every time I heard it, it felt so genuine to that individual person. It wasn't just kind of, "I'm sorry about that." He really, really meant it. So trying to find a statement that you kind of, subscribe to and can remember and kind of say with empathy. So getting into the S of the spikes, we're talking about summary and strategy. And this is very, very important too, as well as accountability. And again, it can be difficult if you're in a maybe high volume clinic, you might not see the patient again, or a locum going back to the same practice. You might not be there for another day or a couple of weeks or a couple of months, but having ownership of the patient and saying, yes, I will look after you to the best of my ability. So try to treat them as an aunt or an uncle or a grandparent, and I'm going to look after you. I'm going to write to the doctor. I'm going to make sure you're seen. It's my day off tomorrow, but I'll be back the following day. I'm going to give you call just to make sure you went to the hospital as I asked you to. If you are going to refer them, give them an idea of what time scale. It could be 3 months, it could be 6 months, it could be 2 years, it could be 3 years. Give them an idea of where they're going to be. And also as well, maybe when you're newly qualified, it's very easy to talk about NHS, but as you kind of get experience, you can kind of begin to offer private referrals too as well. And we do tend to judge a book by its cover, unfortunately, but I got into the situation where I just explained to everybody, you can go NHS, you can go private. NHS are going to take you 3 years, 2 years, privately be seen whenever that you want to be seen. And the majority of people would say, oh, no, not for me, son, I can't afford that. And say, there's no problem, have a think about it. And if you want to change your mind, come back to me. And probably 2 out of every 10, 3 out of every 10 would phone up maybe a month later and say, yeah, I spoke to my family and they're going to pay for my treatment. They want me to go and see somebody, and say, yeah, no problem at all. So again, just give them every option available to them. If they don't want to be referred, you've got to appreciate that too as well. So medical legally, you have an obligation to inform them, and you have an obligation to refer them. If they don't want to be referred, then you've got to document that too as well, and maybe kind of say, well, this is quite important. But if they turn around and say, no, I was in COVID, I lost my wife, I don't want to go to hospital, I've got underlying health conditions, I appreciate your concern, but I prefer not to. You've got to appreciate that too as well, but document it all. And then discuss possible treatment options. Be honest with the patient and say, listen, I'm going to refer you to hospital. When you've been discharged from the hospital, come back to my care. I'll look after you the best of my ability. If you're going to refer them for cataract surgery, is updating the glasses going to make a difference? When they're probably going to have to update their glasses post cataract, and that could be another cost to them, which they may not be prepared for. So be honest with them, and then discuss rehabilitation options. So once they've come back to you, so maybe they've been referred for AMD and there's no treatment. They've seen the ECLA officer, they've been to the old vision clinic, then they come back to you, and again, just going to say, I'll look after you then to the best of my ability. How we say and what we say to them. This was a study done a couple of years ago. I know it's stretched. It was like being hit by a brick. So basically what happened, there was 18 patients who had been diagnosed with an eye condition, And post diagnosis, they had these people who contacted the 18 people over the phone and asked them for the kind of, their idea of what happened and their interpretation and what went well. And the study broke it down into 4 main themes. The process of being diagnosed, it was frustrating. There was anxiety. Sometimes the length of the duration found them kind of undue stress and anxiety. The impact of the clinician's words, and then the search information. You're going onto Google, maybe going onto dodgy websites, untrustworthy sources, and then kind of reflections of what could be improved. So we're going to concentrate on number 2, which was the impact of the clinician's words. And they were talking about kind of, when people are given a long-term condition, this refer a disability, and they can deal with it more effectively when the news is given in a positive, empathetic manner rather than a negative manner, and how the clinician's words and actions can impact the patient. And, it's something that off the cuff, such as it'll never come back again, or you're blind in that eye, or yeah, it's gone now, things like that, can kind of linger, 2 years later, 3 years later, 4 years later. And then also as well for kind of patients who felt they were pitied and poor you and you lost your vision and this is going to impact you and I'm really sorry. They felt probably more had a negative outlook rather than kind of somebody said, well, you really got kind of, one good eye and you can still drive and you're doing really, really good. And also tone of voice too as well, not being callous, not being harsh.